Thank you, Tim. I remember during my time in the Air Force with one of the flying squadrons in the Air Force, we used to have this rule that at least 5% of everything you said had to be true. So I think Tim would do real well with that. All right, thank you, Tim. All right, now Tim's only given me 3 hours to talk. You're laughing, that's a good sign. So I'm going to kind of scream along here for a little bit. Incidentally, how many medical students in here? Where are those? And business students? And nurses? And others? Okay, great. This is an interesting quote by a big man in healthcare in the UK, Cyril Chantler, and he said, medicine used to be simple, ineffective, and relatively safe, and now it's complex, effective, potentially dangerous, and those of you who have been in our clinic and in our hospital are probably starting to see some of that. We built medicine for thousands of years and have a lot of history behind that. As Tim said, I have a little background in aviation, which really is only a little over 100 years. We had to learn a little bit faster. One of the reasons we had to learn a little bit faster is our friends were being killed in airplanes. There's an old saying that the pilot is the first to the scene of the accident. So we didn't have the same, or we had a little bit different motivation for the kind of things that we did when we did in healthcare. I would say as late as 10 years ago, the medical system that we had built looked very much like this. The clinicians were designed to be infallible, and bad things only happen when they screwed something up. And only bad organizations would fail. And that if we blamed them enough and we punished them enough, that was enough to motivate them not to be so careless. If we just work harder, things will get better. I can't tell you how many times I've heard that as part of event investigations. I think we're well along the way to moving to a better model that deals with human error that looks much like this. The risk of failure we know is really inherent, and the more complex you make it, the more inherent it almost always is. And we don't always know where the risk emerges from. Not all of it's foreseeable. Both people and systems are fallible. And even alert, well-trained healthcare providers, although they're crucial, can certainly make error too. Now, I'm going to try to make a little case in pieces today for why teamwork should be able, the appropriate teamwork, should be able to make us better at what we are. Now, Michael Leonard is a safety officer with Kaiser Permanente, and as he points out to us, human error is almost inevitable because there are inherent limitations in what you can do. That's why telephone numbers are no longer than they are, because we can only remember so many digits. We deal with complex systems that are often unsafe. Safety is often assumed, but not assured. Let me see if I can give you an example of that. I was training a group, just happened to be in surgery. There were physicians, nurses, technicians, and so on at a very large children's hospital in the Midwest. And we had little round tables, and as you probably have done many times, you walk into a room and you segregate yourself by where you work. So this table just happened to be full of transplant folks. And we were asking them, what is important to you when you go into surgery? And the team discussed that a little bit, and they wrote these down on a chart, and they said it's important for us that we all agree on our objectives and our goals for that surgery. And I asked them specifically, do you talk about that prior to surgery? And they look at each other and they says, well, not really. And I said, well, you said that was important. Before anything else, why don't you talk about it? And they looked at each other and I says, because we assume that everybody knows that. And of course, my next question is are your assumptions good? And without a doubt, across the board, they say, no, they're not. So then I have to go back to, well, why don't you do that? There are a lot of barriers, as you might imagine, to safety. Catastrophic events, although they're rare, happen a lot more in healthcare than they do in the aviation industry that I came from. However, why do you suppose, incidentally, that aviation accidents are more visible than us losing a patient in surgery or on a medicine floor or in the ED? Why would that be? Yes, sir. That might be part of it. Any other ideas? Flames. I'm sorry?
Flames.
Flames, you bet. It is really hard to hide a flaming airplane at the end of the runway. Really hard to do that.
More people at one time, generally?
More people at one time, you bet. And oftentimes it's just very, very difficult to determine why a patient died. Yes, sir?
It's easy to imagine yourself as being in the plane.
Okay. All right, good. It won't happen to me. if you talk enough to the people that are your mentors, you will find out that it does happen once in a while. Errors are associated with poor performance is an idea that we've had back in our mind for years, and the focus has been on individuals, not on systems and not on teams. It's just a very, very complex environment. Now, I want to show you a little piece of something that I have a lot to do with in our institution. I take what's called a safety culture survey on some kind of recurrent basis in the adult hospital at Vanderbilt. Now, this gets a little complicated, but let me see if I can walk you through part of this. There are about 42 items on this survey, and we make a statement and we ask them, do you strongly agree? Do you agree? Are you neutral on this? Or do you disagree with this? And so on, okay? And then we roll those up, so 3 or 4 questions constitute what we call a domain about teamwork within your own unit. And when we ask our people, how good is the teamwork good on your unit, almost 80% of them said, yeah, it's great. And as you can see, I purposely lined those up from our highest scores to our lowest scores, okay? So I want to call your attention to the teamwork-related ideas. The top one on the list almost universally has been teamwork, no matter where we take that. But look at this. When I talk about teamwork across units, between different units, only 54% said we're very good at that. And then when I talk to them about handovers or handoffs or transitioning patients from one to another unit, look what you see. So only 31% of our people agreed that those go well. And I'll show you some more evidence from other hospitals here a little bit later. Now, I want to tell you my one flying story today, and unfortunately it's not a very pleasant story. I remember this very well. I was around back then. I hope most of you certainly weren't very old back then, but in the middle of the summer in 1989, United DC-10 was flying a leg between Denver and Chicago O'Hare. And when they were in cruise flight, the number 2 engine, this engine right here, catastrophically failed. And it threw fan blades from this section of the engine through the spine of the airplane, which just happens to be where all the hydraulics in the airplane cross over. They have 3 redundant systems and all of them failed. Without hydraulics in a large airplane like that, you cannot physically turn the controls and have them result in any movement to the flight controls, okay? I better ask this question too. How many of you in here are pilots besides Tim? Okay, good. How many hours do you have? 80. You ever flown one of those? No. Okay. So you don't know whether I'm telling the truth or not, right? Okay, number 2 engine fan disintegrates. They lose primary flight controls, and the crew somehow is able to gain limited control of the airplane. Now, they found out inadvertently, I'm not going to go into a lot of details about how this worked, but they found out inadvertently by using the throttles on the number 1 and number 2 engine, they could get the airplane to pitch up a little bit, they could get the nose down a little bit, and they could actually turn more so in one direction than the other. So they had some limited control, and they diverted the aircraft into Sioux City, Iowa, where it crash lands. And that's what the skid marks look like across the runway at the time. This is actually a screenshot from the news media. They had been airborne with this emergency for a number of hours, so the news media had time to get out there. That's not a good thing for the aviation industry, but they didn't know where they were coming in, which direction, so they didn't get a very good picture, which is probably fortunate. The bad news is 111 people died in this crash. The good news is, the remarkable news is that there were 184 survivors, to include the entire flight crew. It was just absolutely amazing. This is the icon of accidents for aviation pilots. I have never seen another accident. I've read hundreds of accidents and hundreds of medical events, and I've never seen one where teamwork was more successful at helping with the outcome than this. This is actually Captain Al Haynes, who was the captain of that airplane. But what I want to do is I want to show you a couple things, or tell you little tidbits about things that happened on board this airplane that were responsible for this success. And then I'm going to kind of make the transition a little bit into healthcare, and we'll see if there's any real carryover there. You know, I've often heard in healthcare, especially in safety circles, the idea about let's level the playing field. If we have everybody equal, then everybody's able to speak up. You and I both know that's not really the way it works. If you've been a third-year medical student and you're on rotation with an attending, you know there is very definitely a rank structure there. Okay, we use that to our benefit, both in the service and in flying, because why would we do that? What would we expect most out of a captain on an airplane? Why do we pay him the big bucks?
Good judgment.
Judgment? Resulting in what?
Problem solving.
Problem solving, you bet. And we're going to talk about that a little bit. You know, flying from Denver to Chicago isn't really that hard, but problem solving is a really big issue. Now, when this guy shows up at the airplane, the chances are significant that he has not met his co-pilot before. So he will show at the airport 1 hour prior to takeoff. The flight attendants are even worse because they don't show up at the same place. They show up at the gate and they show 30 minutes prior to departure, and their responsibility is to start loading passengers as soon as they're ready. Okay? So although there are some ways to form the team, the hierarchy certainly is defined by not just rank but position. One person on that flight deck will be identified as the pilot in command. That's a licensed responsibility. That's the person that the FAA will hold responsible for any untoward events. But the technique on how that captain puts together that crew is a function of who the person is. And you've probably seen much the same thing in the teams that you've worked on, okay? This is kind of interesting though. I put on there originally, issue an invitation to speak up because it's such a powerful tool. That is such an important issue in aviation that it's not really an invitation, it's an expectation. Now, I worked for Delta Airlines for a little bit. I was not a Delta Airlines pilot. I got to fly with the crews once in a while. It was obvious that I wasn't a pilot. I didn't have any stripes on my sleeves. And every single time I flew with them, the captain looked at me and said, if you see anything that doesn't look right, our expectation is that you say something about it. Okay? Now, you'd think this makes sense too. It's kind of relative to my little story a little earlier about the surgical team who didn't discuss their goals and objectives. But how about talking about our roles and responsibilities? On this particular airplane, it became crucial. Now, what happened is about the time this emergency took place and the engine blew up, the co-pilot was flying the airplane. So when that happened and the co-pilot said, I'm unable to move the flight controls, the first thing that Captain Alhain said is, I've got the airplane. In his report later, he says, that's the dumbest thing I ever did. Why would he say that? What's the point?
Crew pilot didn't give him the plane?
No, there actually is a systematic way to do that. He grabs the controls, shakes them, and said, I have the airplane, and it's his discretion to do that.
Someone else already had it.
Somebody else had the plane, he had to take it from him, but why would he say that was stupid? Ties up his decision making, because now he has to solve problems, make decisions, and fly the airplane at the same time. Subsequently, he gave it back to the first officer and says, you have the airplane, and he says that's the smartest decision he made. Now, he did another interesting thing. You know, we sit in the comfort of this room any afternoon, and I talk about who your team is. And if you've been a medical student, even if you haven't, but you've been in our hospital, and I talk to you about that long enough, you'll come up with a squad of about 50 people that you consider your teammate. In reality, you almost never deal with all those people at one time. And indeed, the team that he was with that day changed. One of the first things that happened was there was a training captain back in the back, deadheading we call it, or just riding along. And when he heard the engine blow up, he identified himself to the flight attendant, and he said, I'm a United Airlines captain, I'm a training captain, ask the captain if he needs some help. Captain Alhain says, you bet, send him up. So he came forward, he was very, very instrumental in helping them out. On the other hand, they spent a long time talking to United Maintenance in San Francisco. And United Maintenance routinely told them, well, that can't happen. You mean you only lost one system, right? No, we lost this. And they bantered back and forth, and they were so unhelpful. Finally, Captain Alhain turns to his second officer, and he says, hang up the phone, we have things to do, and they're not being a help. So he really had to kind of sort of sort through what was important and what wasn't. Communication in an airplane is a little bit more of a shared structure in aviation than it certainly is in healthcare. Communication is meant to be very clear and concise. I'll give you an example from this. I always have to laugh at police shows when they talk about reading license plates, and it's always Apple 1, 2, or something like that. You know, aviators have a phonetic alphabet. It's one of the very first things we learn. A is always Alpha, B is always Bravo, C is always Charlie, and so on. And we memorized that. It was well researched so that every letter is discriminate from another and so on. That's just how we start learning how to communicate. We always ask for acknowledgement. If I'm cleared into Nashville's airspace, they expect me to acknowledge that. I was telling Tim back in late June, I had an opportunity to fly into Nashville International, which I don't normally do in little tiny airplanes. And I called and she gave me a clearance to a right base to 1-3. And she expects me to respond with, Roger, understand right base to 1-3, or I'm not approved to follow on. Now, here's an interesting concept. This idea about sharing a mental model and developing that same mental model, and I'll spend a little bit of time with that as we move along. Now, there are several sub-teams, if you will, that this crew has to form. One is between the flight crew and the cabin crew. Now, since this emergency, it's even become more difficult because that door is shut and bolted, okay? So that's pretty hard to do. There is another shared mental model that must be developed between the flight crew, certainly, and air traffic control. That was a big issue going into Sioux City, Iowa. And there is an organization called Dispatch, which is back at headquarters, that shares the responsibility for loading, for flight plans, for diversions, for all that kind of stuff that the flight crew has to coordinate with. And less often than that, once in a while they have to call up maintenance, ask for help, and once in a while they have to call for medical support because they have a passenger who's shared some medical problem. Now, I'll get back to that a little bit later. So, the other thing that we have to our advantage really in aviation that we don't have so much of in medicine is we have a way to declare an emergency. That's exactly the words we use. Cessna 4284 Quebec is declared an emergency. Those are magic words to us, and they mean very specific things both legally and technically. If I call up Nashville Approach and I say, look, I'm having a problem up here, that is not nearly the same thing as me calling them up and saying, I'm declaring an emergency. They're required to clear a path. I have priority over all other airplanes, and so on and so on. Our communications are much more structured than they are in healthcare. I have a set of emergency procedures that come in different forms. During takeoff, for instance, I'm required to know by heart the 2 or 3 procedures that are critical during takeoff because I can't pull out a card and read them. For those emergencies that are a little bit slower in coming about, we have a little checklist. And for those who don't, where I have longer time, sometimes there's guidance and sometimes there isn't. There was not guidance on this flight on how to fix that problem, and there was no guidance on that guy who landed that Airbus in the Hudson River. That's never practiced. That is not an emergency that's in his procedure book. And we have standardized ways of making approaches to airport and for landing. Now, let me distance ourselves just a little bit from the accident and talk about some of these lessons learned and how they might apply in an airplane. Now, I'll be frank with you, during your junior years in healthcare, some of these are not necessarily within your reach, but some of them eventually will be. It's a big deal to know who your team is. In most of our clinical areas now, our units now, we have 2 ID badges, and we require that of all our people, so that one's always up and you can read it and see it. Now, as you follow around residents, you're going to note they don't always do that. They're busy, they don't always pay attention, maybe they don't think that's important. You listen to their conversations, and they rarely start out with, hey, this is Bob Jones, I'm up on 8 North, and my patient is so-and-so, but that's a critical issue. Know your team's name. Boy, there is nothing wrong at all with walking up to a nurse or a resident or even a tenant and say, hi, I'm Tim, what's your name? Okay, make eye contact with them. That's a big issue. If you don't think it's a big issue, watch how conversations are particularly started. Here's a good idea for anybody that's passed along information and wants to verify that the other person got it. Ask a series of open-ended questions. How useful do you think it is if I look you in the face and say, do you understand what I just said? How many of you think that's a useful question? Raise your hand. Why do you say that?
A lot of times people are afraid to admit that they don't know what you just said.
Okay, so would that make that useful or not useful question? You know what my point is. I guess my point is sometimes somebody will look you in the face and they'll say, yeah, I know exactly what you mean, and I don't have any verification of that. Now, in aviation, because our language is structured enough and shared enough, I can typically ask for what's called a read back. You know, read me back the clearance that I just gave you, and we know that. In healthcare, that's not always the case, especially with patients. But another method you might think of sometime is something called a teach back. This is what we expect you to do when you go home. Now, can you teach that to me? Okay. We set expectations to avoid these things. Sometimes it may sound stupid, but talking about the things that you normally assume is a very, very useful procedure. And this idea about inviting people to speak up is enormously helpful. It's what Michael Leonard at Kaiser calls psychological safety. It's enormously powerful if you have let's say Nancy Brown, who is the chair of internal medicine, gets your little group and you're rounding with the group, and she stops a second and she says, look, while we're rounding, if you see something that doesn't look right, our expectation is you speak up. If they don't say anything at all, you're in doubt, okay? And action support words. So you can tell your people one thing, and if you don't follow through with that, if you don't treat it as a psychologically safe zone, then it won't work very well at all. Now this is a little piece of data that looks complex, but I want to show you something. I told you I would get back to this idea about teamwork. This was data was from studies by Brian Sexton, who was then at Johns Hopkins. And he is a researcher in safety climate. And what he did was he asked nurses, if I can get my little light here, he asked nurses to rate physicians. That's the little, I'm colorblind, but I think those are the darker orange bars there, okay? Asked nurses to rate physicians on the quality of their teamwork. 1, it means it sucks. 5 means it's great, okay? And then he asked physicians at the same institution to rate the nurses on their teamwork, okay? All right, so these 2 bars right here represent one facility, and the nurses here rating the physicians rather highly, and the physicians are rating the nurses very highly. So what could you say about the organizations that are right here on this chart? Sorry?
An inverse relationship?
Well, it looks to me like they're telling us about the same thing about each other, right? I haven't gotten to the other side yet.
Yeah, that's
We're going to get to that.
fine.
All right. Yes, sir.
Well, they seem to have shared expectations.
Okay. That's what we might think about that, certainly. Okay. What do you think it says about these on the other side, where the nurses say, no, it's not really that good, and the physicians saying it's great?
Lack of communication between the two?
Possibly. It could be to a lot of things, right? But one person thinks we have a great team and the other person doesn't. So I thought that was pretty revealing from some of his work. Now, let me talk just a second about this idea about defining roles and responsibilities. Actually, I built this slide to talk to the ED residents in our house. Anybody here been in our ED? Okay, I hope that was as an observer and not as a patient. But you know, I made the point that you deal with your team differently depending on what's going on. A normal situation actually in the ED doesn't look normal to you or I because it looks rather chaotic, but it really is. We put a lot of patients through our ED every day. And then there's something that I personally, these are my words, I called somewhat normal operations. That's like when we have an admit, we have a transfer from somewhere else. Boy, those come in all kinds of forms. Some of the transfers are the doctor telling his patient, just go over to Vanderbilt and go to the emergency room. Sometimes they're well scripted and we know what's going on, okay? And emergencies and contingencies here has less to do with the status of the patient than it does what's going on in the ED. It's always full, we always have admitted patients there, but we don't always have a chemical spill. We don't always have water rolling in our threshold. We don't always have a power failure. Those kind of things are emergencies and contingencies. And then that would really lead you to say, if you have good situational awareness, that would lead you to say, what exactly are my responsibilities? And what are the responsibilities of those associated with my team? And how am I going to carry those out? Can you imagine being a young intern and the senior resident looks at you and he says, watch that blood sugar. Now, what does that exactly mean? If you're not sure, it's a good thing to find that out and find out what your role is versus the nurse who might administer insulin and so on. Okay? Now, I'm going to switch channels, but not very much. I want to really talk a little bit about communication, and I'll show you a really interesting study. This was done by Kevin O'Leary at Northwestern in Chicago. And this is kind of interesting because he took a sample size patients, 229 patients, and he asked questions of the physicians for those patients and the nurses for those patients. The first piece of data I'll show you shouldn't be any big surprise that 89% of the patients said they expected their nurses and physicians to talk to each other. Okay, now look what happened. Now they would go up to the physician and said, what is the nurse's name for that patient? And it doesn't surprise me at all that a little over a third of them knew that. This does surprise me that it's even this low. They would ask the nurse the name of the patient. Once in a while it gets a little more muddied when there are residents that come and go, okay? Then they said, have you talked to the nurse? 61.5% of the physicians said, of course I have, and 50.3% of the nurses said, no, they haven't. Okay? Even more serious than that was they would ask the physician, what are the planned procedures today? And then they'd ask the nurse the same thing. And they did pretty well, actually, on this. Almost 89% agreed on it. But look at these. In this case, what are the planned tests for today? Look what the levels of agreement were. And for what are the consultations for today? What's the primary diagnosis and what are the medical changes? If you spend any time in the hospital, you should already realize that of the electronic records we have at least 2 sets. At least 2 sets. We have HED for the nurses, which is what they chart all the work they do. And then we have STAR and associated documents for the physicians. Okay? All right, so let's get back to this idea of a shared mental model. Shared mental model, common understanding of what's happening, what's going to happen, and what team members can expect from each other. Okay? Here are a couple ideas on how to start building that mental model. If you talk to somebody, how about identifying who you are first? How about finding out who they are first? And how about telling me what patient you're talking about? You'd be amazed at the number of resident sign-outs I see for 12 or 15 patients where nobody mentions the patient's name. And it doesn't happen every day, but once in a while we'll have similar names, or we'll be talking about different patients and don't know that. And if you're going to give me the big picture, how about starting with the situation? I'll show you why we don't always do that here in a little bit. Give me some context to understand that. Tell me what your assessment is and tell me what recommendations are. If you heard of SBAR handoffs, it kind of sort of follows that a little bit, okay? And then maybe we should discuss roles and responsibilities. And here is a really interesting thing to do. What can potentially go wrong today? I don't need a laundry list. How about if we talk about the most likely thing to go wrong today? Because it develops a little rapport between you and I about what our roles and responsibilities are. We found that very, very effective in flying. Now, where did things fall through the cracks? Well, the systems are complex. You know, if you've been in our ED, you've probably seen a fabulous electronic whiteboard we have. When we first put it in there, it didn't talk to STAR at all. Not at all. Now, there are reasons why we did that. I'm not trying to be critical, but we have systems throughout the hospital that haven't talked to each other. Communication is an issue. We don't have standards for communicating, or not very many for our house like we do in the air. Handovers or handoffs are enormously difficult. Incidentally, I'll tell you a little bit about those words. The standard terminology we've been using for years is handoffs. My boss, Julie Morath, who's our Chief Quality and Patient Safety Officer, didn't like that very well. And her point was that a handoff can be something that you throw over the fence. A handover means there's somebody there to receive it. So she prefers that, and we're starting to use that more. Failure to recognize what's going on and failure to rescuers have certainly been factors. So we talk about building standards, building protocols, and building procedures, and that is not always a popular thing to do, especially in an academic medical institution. Why do we do that? Because it reduces variability. How many of you have fired a weapon? If you've ever been out to the range and tried to fire a weapon with any accuracy, I'm really, really, really bad at that. You know exactly what accuracy is, and you know exactly the point of reducing variability. If I have standards and protocols or procedures and I know which one we're using, that gives me a little bit better shared mental model of what you and the rest of the team are about to do. It allows me to anticipate and predict what others are going to do, and probably even more importantly, to determine when those things aren't happening. Believe it or not, it gives us some agility and resiliency. And I'm going to show you a great example from flying. Very last thing I show you. Here's an example. How many of you ever heard door to balloon time? You know what that is?
Yeah, when a patient comes in who with a heart attack, you need to get them up within a certain amount of time, put a stent or a balloon angioplasty into his heart.
Exactly. So it's the time from the time they show up at our door, an emergency department, till the time you're inflating a balloon in that vessel in their heart to open up the vessel. In 2005, CMS and the Joint Commission made it imperative that we know what those times were, and we didn't have a clue because we'd never measured it. We didn't know it was variable. We didn't know the steps that were involved. This is actually a report from a single patient on one day, and these are the steps we routinely track to the minute. When did they get to my ED? When did we take the EKG? When was Life Flight notified by the ED? When was Life Flight activated the cardiac cath lab? When did they get to the cardiac cath lab? When did they begin the diagnostic and into the diagnostic? And when did they inflate the balloons? and we have goals for those, and we're great at meeting them. Because we now know what the processes are, we know which parts of the process have variability. For instance, we found out that once the EKG was printed out, first it went to a resident, then it went to another resident, then it went to a cardiology resident, and that doesn't happen in our ED anymore. No more. It goes directly to the ED attending, and the ED attending has the authority to open up the cath lab anytime, okay? But you can see we've made tremendous changes. This is a good place to have a heart attack. Let me just talk for a second about standardizing communications. Michael Leonard likes to point out to us that one of the reasons that we have such difficulty talking to the team members is because we train the team members differently. You know, we send nurses to school and we train them to be very, very narrative and descriptive. And I've heard this more than once, I don't make diagnoses, so I have to be rather descriptive about it. And so we've argued about this one day when it got to that assessment part of the SBAR. Is there any reason you can't tell me what you think is going on just because you don't make diagnoses? Well, if you're bred differently, that's the way you're taught to speak, okay? I go home, Carolyn, don't tell my wife I said this. I go home, my wife is a nurse up in Children's Hospital, and she comes home and spills her guts about everything that's happened that day. Well, out in my garage, 10 feet from where we're standing, is my tool cabinet, and I have every tool. These are needed tools. You got to understand that, right? Now, I can tell all the women are laughing at me, and all the men know exactly what I'm talking about. I need these tools because I fix things. That's why I'm there. So she starts rattling, I interrupt her, and I said, I know how to fix that. All you got to do is this. And about the third time I interrupt her, she says, shut up and listen to what I'm saying. Why is she doing that? Does she want me to fix her problem? No. I'm a very slow learner. It took me a long time to realize that, so I go out in the garage and play with my toys. My needs. Okay. Physicians are trained to be problem solvers. Where are the nurses in the room? Oh, good, great. Now, you've probably seen this, especially if you've had to call a resident in the middle of the night, especially if they were a cross-covering resident, asking to pull out their paper and see how many patients are on that. So I'm an intern, I've got 30 patients, I barely know what I'm doing, and you want to give me a 20-minute story on your patient. Do you see the disconnect, the potential disconnect? So this is why this is part of the reason why we have so much difficulty with our handovers. We're trained to be problem solvers, just tell me what you want to do, I'll do it, we're gone, and then we complicate that with differences in gender and culture, pecking order, and so on. And so it's a point of view on how I'm going to deal with my team. Here's a real interesting example. Just prior to the time when I came here permanently, I worked for a training vendor in the Memphis area. So I was doing work here, and when we had trained thousands of people, finally, one of the procedural departments said, what can you help us do with this training? So I said, well, let's start with developing a shared mental model around the procedure that you routinely do. How well does that go? And they said, it goes terribly. The nurses said, you know, I want to know two things. First of all, I want a little bit of respect. I'd like the guy to know who I am. And second of all, I'd like to know a little bit about what's going on. And the physician said, you know, all I want's a nurse that knows what she's doing. I thought, well, that's probably not a good way. So what we did is we developed a little pre-procedural briefing. Now, we would probably call that a timeout today, but we didn't have timeouts back then. This preceded that. And I didn't really do very much of this. All the meat in the middle of this were the things that they said were important to them. It was important to them that they agree and verify the procedure they were going to do, the consent was signed, if there was any adverse patient history, and so on and so on. All I ask them to do is know your team members. But we need to do that quickly. It needs to fit in with your flow, so we're just going to put them up on a board, and the only people we'll introduce are the new people, okay? And at the end, you ask the question, or you invite people to speak up, ask them if they're ready, and then you complete the briefing, okay? Worked great. In this procedural area, they blew this up in size 86 font, and they put it on a chart, and they laminated it, and they put it on the wall, and we went in search of a fellow. And we said, come in here, stand in front of this thing, and brief your last case. It's perfect. The attending loves it, until one day, one of the attendings turns his back on this and says, I don't need this checklist anymore, I know what I'm doing. And as they progressed, we saw exactly what we expected. You cannot remember all those things by heart. So we audited it, and this is what we found out. They were talking about adverse patient history and precaution, something called precaution level, even though I've misspelled it 100% of the time. And about, let's see, 90-some% of the time, they initiated the briefing as we asked them to do, and the procedure was announced. Look what's on the bottom of the chart. So less than 20% of the time were we confirming who we had. So it's not just a matter of cookbook medicine. You understand? You see what I'm getting to? Okay. Handovers are enormously difficult. This is some data out of MGH, Mass General. Barry Kitch is up there, and he did a survey on 108 internal medicine and 53 surgery residents immediately after their last rotation. And this is what they told the team about their last rotation's handoffs. Almost 60% reported at least one patient experiencing minor harm because the handoffs weren't handled very well. Almost an eighth reported major harm to a patient because of the handoff. And almost a third only rated the handoffs as fair or poor. And almost 38% said they were unable to provide accurate or complete information to either the attending or the family because the handoff was so bad. Okay? So that's the kind of things that we face. This is kind of an interesting permutation of that. This was developed by a team under the guidance of Dr. Matt Weinger. Some of you may or may not know him. And it was designed to elaborate on our S-bar handoff between the OR and the recovery room. So you can just kind of see the situation, the background, the assessment, and there's supposed to be an R down there for recommendations. But the whole idea was that it was pre-populated using the VPIM system that they use in surgery. So it had all this data on it. Now, we don't have to waste time talking about every piece of data. This is printed out during closing in the OR. The circulator pushes a button, it prints out in the PACU so that we roll the patient out to the recovery room. You have a copy and I have a copy. I'm anesthesiology, I've been with the patient for 3 hours. I said, here's your copy. These are the kind of things that are important to you. And there's some, yes ma'am.
Just wondering, what is S-bar?
I'm sorry?
What is S-bar?
Oh, I'm sorry. I'm glad you asked that, okay? Let me finish this and I'll come back and talk about that. It works relatively well. As a matter of fact, there's a pretty decent study from Britain, from the British Nursing Journal, to indicate that it's about the only way we know of reliably getting all this information from one place to another. You ask about SBAR. SBAR is an acronym that stands for Situation, Background, Assessment, and Recommendations. When we were tasked from the Joint Commission in 2005 with developing a standardized format for handoffs, that's what we adopted in our policy. Sometime we have a lot more time, I'll tell you how we did on that. Okay? That was a pretty good example, something that I think worked very well. Certainly what we knew from aviation and what we're starting to learn in healthcare is we have to have a quiet, uninterrupted environment if we're going to have a successful handover. As you all follow residents around the house, you'd be amazed at the places that they do these handovers sometime. If it's a consistent format, if we use that every time, it works a little bit better. Medicine has a pretty consistent format now. The last time I was in the ED, their format was kind of a blank sheet of paper, so they vary a lot. And a common understanding that we uniformly use that, and it's got to be pretty straightforward. You know, we had one in one of our ICUs, and we had patients coming up there for the ICU, and because they don't want to use the format anymore, the nurses put a wide piece of tape on the Mayo stand and took all their notes on it, because they were copying as fast as they could. And we got to have an opportunity to ask questions. So why do good things go bad in healthcare? Why do they go bad in flying? It's the same thing. When the operating environment that we're living in is too variable, we develop personal workarounds, personal fix to team-related problems that only work when those team members are there and I'm there, because they're different when somebody else is there. Now the fixes depend on the presence of specific people and making sure that I'm okay and I'm feeling okay and I'm healthy, or the memory of specific people, okay? Now, the last thing I want to show you, I'm going to kind of revert back to aviation for a second. I told you standardizing these things can sometimes add enormous agility to what you do. The reason they do that in aviation is because we have all these little packages of standards and we can rearrange them however we need to in a hurry. And this is a great example. These are the events that happened on 9/11/2001, and they started with American Airlines Flight 11 crashing into the World Trade Center. Okay? This is what I want to point out. All those things that those arrows are pointing to are relatively standard procedures. We know how to do that. Now, the unknown threat at that time, we were very, very confused about what those 4 airplanes were doing that ran into 3 buildings and ran into the ground in Pennsylvania. But we had almost 4,600 airplanes that were airborne and were ordered on the ground. What did we do with those? Well, because we were able to do all those standardized bits and pieces, we got every one of those airplanes on the ground safely in 2 hours and 31 minutes. I say we, I didn't have anything to do with that, but which I think is a rather remarkable idea of using all these little standards in a way that can give us enormous flexibility. Okay. Well, that's all I have for today. I appreciate your time, part of your pizza. We're not doing questions, are we?
We can do so. Yeah, certainly.
Yes, sir.
You talked a little bit about handovers and with the changes with resident work hours in the last few months. You know that the number of handovers has increased. And I wonder if there's any data yet to show if adverse events have increased or stayed the same or decreased even since these handovers have increased in number.
To my knowledge, there is no data. I know that once we implemented the last round of limitations on residence hours, that we were unable, the literature was unable to show us that there was an improvement in safety at that time. Yes, sir?
How do you measure compliance of something like a handover?
That's a good question. Part of that you can do, and part of it is a lot harder to do. Part of it you can do like the one I showed you, where we audit it. In this particular one, we had a separate area where we could stand and watch it. We have cameras actually in our ORs, so you can see if they go through the steps. What I can't do is see if they're very well, is to see if they live in the spirit of that handover. Who was doing, you were on the team to help us audit in the ORs, right? Okay. So part of it's easy and the other part of it is a little bit more difficult. It's not easy.